I'm delighted to welcome Dr. Sarah Combs. Thank you so much for agreeing to be interviewed today, Sarah. As you know, I'm Laura. I'm just going to ask you to introduce yourself for the video, please.
Okay, well, thanks for inviting me, Laura. Yeah, I'm Sarah. I'm a clinical nurse specialist, an associate clinical nurse specialist in a hospice, and I'm also working as a research fellow at a university. So I'm living the role of a clinical academic.
Living the dream.
Living the role, yes.
So I'm really interested in your research, and we're going to not be able to kind of go into the fullness, the full depth of it all, but you will be able to find some links after the video if you're interested in finding out a little bit more. But I wonder if you could start by telling us a little bit about how you kind of came up with the question in the first place. Did it come from clinical experience, from your own practice?
Yeah, absolutely. So as I say, I work in a hospice, and one of the key things that we do in hospice is advanced care planning. And we know that everybody, according to the end of life care strategy, it's in there that everybody should have the opportunity to have these conversations as they come towards the end of life. But we were finding more and more that people that we were looking after in the hospice, or people that were being referred to us, were older and people living with frailty. And whereas people perhaps with a specific diagnosis, a cancer or a heart failure or something like that, advanced care planning conversations tended to happen. Didn't happen so much with older people living with frailty. It wasn't something that they were engaging with for whatever reason that might be, but we were having more and more people coming into our service. And at the same time, we also know that older people living with frailty are really vulnerable to sudden deterioration. So the point of advanced care planning is that you decide what it is you would prefer the end of your life to look like, what the care that you would prefer and everything, so that if you lose mental capacity and you can't make those decisions in the future, people can make decisions for you, the professionals and your family. And because older people living with frailty are so susceptible to these sudden deteriorations, it's really important to have these conversations, but they weren't happening. And so that's where it kind of came from, really. How can we enable these conversations to happen for the older people, but also to support the professionals to start the conversations as well?
Yes, it's almost like the group of patients for whom it would have the most tangible benefit were the ones who are engaging with it the least.
The least, exactly. And we're going straight in and out of hospital all the time, sometimes appropriately, but quite often inappropriate admissions. And yeah, exactly. We really needed to get to those people.
Yeah, yeah. And like you say, I guess the looking at what's getting in the way is going to take into account concerns of people and their families, but also confidence of professionals and things like that. So
yeah, absolutely. So the first work I did was around that integrative review, and in that, what I thought I was going to be looking at was exactly what you said, the older people and the professionals and the families. But it also became clear that the system could be a real barrier or a facilitator, and organisations themselves as well. So it's not always as easy as change A then becomes B. You have to think about the whole thing in context.
Yeah, immensely complex. So so from a sense of something being needed, how did that give rise to you getting involved in kind of actual real life research?
So I applied for my PhD through the NIHR and was luckily funded to do that. So I then had to look at what I wanted to do and wanted to look at what those barriers might be. And then I wanted to ask the older people what they thought they were. Because when you look at the research, the papers are really, of course, incredibly useful, and you need to start with that there. But the amount of older people that had actually been asked and been engaged with, rather than proxies, so family of people who had died, or professionals or organisations, that the number of older people is so small. It was really important to me to ensure that I talked to older people themselves living with frailty and their family members about it. So it was this review first, then I was going to do interviews with older people living with frailty. I was going to film them. I was then also going to do a Delphi study. So I did that with professionals throughout the whole of the UK, paramedics and nurses and doctors and all sorts of people, as long as they dealt with community-based older people living with frailty and advanced care planning. I wanted to hear, so district nurses, everybody. And then apart from COVID, what was going to happen was I was going to take all that information together. It was all going to be analysed. It was all going to be analysed also under behaviour change theory that I used, which you can look in the papers if you're interested. I was then going to get everyone together and collaboratively design an intervention. So older people living with frailty, professionals, voluntary sector, people who are so important in their lives, and come up with an intervention. And then COVID happened, so that didn't quite happen. So I developed it a bit more theoretically, but with a lot of PPI. I don't know whether you're dealing with PPI, so patient and public involvement was really important to ensure it was relevant. And then I tested the intervention in practice as well. Wow. So that was the PhD.
Yeah. From a spark, from an idea to a practice change. That's quite a journey. I wonder if you could expand on a couple of things that you said in that, just for just to aid our understanding. Could you tell us really briefly what a Delphi study is?
So a Delphi study is where you're doing a survey. Well, there are, to be honest, there are many, many different kinds of Delphi studies.
Okay, let's start yours.
So the one I used was an adapted one where I started with questions because I'd already done all the work of the review, and so I knew what I wanted to ask. So it was an adapted Delphi, and it was an eDelphi because I did it online. So you get experts. Now the experts could be whoever is expert in that particular field. So it could be patients, it could be family members, it could be professionals. In my case, I wanted the professional view because I was going to interview the older people. And then you ask them to rank each of these questions, and you find out which is the key. You keep ranking and ranking and ranking until you get to the final expert opinion on each of those questions. But as I say, mine was slightly different, and you can start Delphis literally with a blank piece of paper and a group of experts in the room. So I don't know if that's helpful.
That's really helpful. Yeah, again, I'll put a link on for people to read more about that. But that sounds like the purpose of that stage of it was very much to kind of gather information from various people involved in various ways in the advanced care planning process or the absence of it. So including sort of
exactly.
That it makes sense to me.
Yeah, I'd got the information from the integrative reviews from the papers, and that's great, but a lot of the papers weren't UK based, they were in America, and the advanced care planning is very different. So I wanted to know, but okay, that's great, but what does that mean in this country? So it was about what does it mean contemporaneously and in this country. So that was the point of the Delphi.
Yeah, absolutely, that makes sense. So then moving on to just one more thing that I wanted to refer back to from what you said earlier, that a lot of the information that you found was very much from proxies, so it's from health professionals, from families, so that the voice of the older people living with frailty was very important to you. This is a double question, which I know I shouldn't really ask, but what do you think was the reason their voices were so missing? And linked to that, did you encounter any obstacles in the kind of design of your study?
So why were the voices missing? I think people don't always, as researchers, I'm not sure we're always focused in on the voices of specific people. And with palliative care in particular, it can be really tricky to hear the voices because of ethics. So sometimes ethically, it can be really difficult to persuade your ethics panel that this won't be an additional burden for somebody who's coming towards the end of life. So I knew I was going to have challenges around ethics because I wanted to talk to older people who were living with frailty about death and dying. And I was going to be talking about those words with people that were probably the same as their mums and dads or their grandparents that were on this ethics panel. And I was going to talk to them about death and dying, and I was going to film them doing it. Obviously, they had to agree to all of this, but from an ethics perspective, that's quite tricky. Anything to do with end of life care, it can be a real barrier to research. So I think sometimes it's easier to ask proxies than it is the people.
Yeah, absolutely. So did you, I know the process of going through ethical approval is incredibly complex. Without kind of going into it in like full IRAS detail, how did you reassure the panel that this wasn't necessarily going to be something that was burdensome or something that would cause distress?
So there's two I feel two really important things is, one, the research is so important. You need to look at what's already out there. You need to look at your guidelines that are already out there, and you need to be able to quote from them. So for me, I was able to say, actually, if you look at the evidence within palliative care, it says that people that are involved in these kind of research studies, they actually find that it really helps them at the end of their life, because they feel that they're giving to other people. So it's actually a real benefit. And the second really important thing is to ask your patient and public involvement. You need that involved, in my opinion, right from before you even start your study. And you need to be saying, okay, what's going to work, what isn't going to work, what will work with these people, what won't work with these people. So you talk to older people living with frailty in my case and say, will that work or not? And then you make sure you put it in your ethics panel approval, because they will have patient and public people look at that to see whether it works or not. And as long as you've covered all of those things, and also you need to make sure you're being careful with the people. So you need to have a distress protocol. You need to ensure you're trained to be able to do this kind of work. So everything you can do to try and help the panel feel that you're really supported within your team and you know what you're doing, and you've got protocols there just in case anyone did get upset.
Yeah, of course. And I would imagine that's actually a really helpful process to have gone through in any case, to make you perhaps the most mindful that you could possibly be about any potential impacts.
Yeah, absolutely.
So skipping forwards a little bit then, so you undertook these semi-structured interviews, in-depth interviews, and had this sort of idea about this kind of overarching idea about looking at facilitators and barriers to advanced care planning. Could you talk a little bit about what happens in real life when somebody is just telling you a kind of story or answering a question, and you're kind of making sense of that in terms of your own question? I know that's a really kind of ethereal thing to ask, but I think it's something that, having done research, is really interesting to me, that kind of process of turning the mess of qualitative data into something that makes sense to the consumer of research, the implementer of research.
So you're talking more about the analysis side of it than necessarily when you're in the room.
Yeah, I suppose. Yeah. I mean, I would love to talk about what happens in the room as well, but I guess the interviews follow the process that they follow, and then you are left with a big transcription of
huge amount of data. Yes,
transcription of all these kind of words and sentences and stories and people and narratives, and so what happens there?
You absolutely, I mean, there are lots of different ways to do thematic analysis if that's the one that you choose to do. But for me, you absolutely have to embed yourself in that data. And for me, I feel brilliant that I had most people agreed to videos. Only 2 of the older people didn't, but I still had the audio recordings. So I not only had the words and I not only had the sound, but I could see them again, and you get so much more context. So it was a real case of re-embedding and listening. So your question might have been one thing, but they might have been telling you something quite different. So it's really listening critically to what it is that they are actually telling you, and then working out where your barriers and facilitators are. But first of all, it's really about understanding that data to such a great degree, and it's about trying and trying again. So I just had lots of A3 bits of paper with lots of scribbles as to what I thought the main themes might be, because you need some way of putting these together to make some sense. Because I think I had 18 different interviews. That was a lot of data, and most of them we thought they'd be quite short, and none of them were short. So there was a lot. So you have to be able to understand it. So, and you just keep thematizing it, and then thinking, actually, that doesn't quite work, and just working it until it makes sense to you. And again, using your PPI, kind of, does this make sense? Is this does this make sense? So it's a case of you build up from the ground up with your codes, and then your themes, then you realize that there are sub themes within each of the themes. So it's just working with it over and over and over and over until it makes sense, and then you can give that story to somebody else. Once you can draw it really clearly, generally that's when you're kind of almost there.
Yeah, that's a really articulate description, and I think it required the hands as well.
So sorry.
required the non-verbals as well to kind of make sense of it. Just quickly, the PPI, did your patient public involvement people look at raw data and then look at the themes you'd found, or were they looking at the themes themselves? Like, did they kind of take a part? Did they have a part to play in the analysis itself?
They didn't. We talked about this a lot when it was coming through ethics, and we decided that was something that was just too much, because I wanted to ensure that I had older people living with frailty as part of the PPI group, and we just felt that was just too much. And also, with a funded PhD, you have to be really careful with your time frame. I just didn't think, to be quite honest, that I had enough time. And because I was also then overlaying this behaviour change theory, that there was additional complications.
Okay. It's like so, theoretical understanding, they probably would have required a lot of support to.
Exactly. Yeah. But they looked at the themes and the sub-themes, and there was a description of each of those, so they could give feedback on whether they thought they were sensible or not sensible.
Yeah, that makes sense. So I'm really mindful of time. It's skipping away because I'm very passionate about this topic, and you talk about your research with a lot of enthusiasm, so I could spend a whole morning talking to you about it, but I mustn't. So I wanted to draw it to a close with one more question, which is around I mean, you talked about kind of developing the intervention. You talked about kind of some of your supposed reasons for a lack of engagement in the advanced care planning process for this population. Could you briefly describe how the findings of the study have turned into a change in practice? Would that be something you'd be able to?
Yeah, sure. So the intervention ended up being, it wasn't what I anticipated, but it's where the research went, and it ended up being a training session for professionals, and it was around getting them to start these conversations. Because if somebody has all the information in front of them and they don't want to engage with ACP, that's absolutely fine, but it's ensuring that people have the relevant information. So the kind of barriers and enablers that came up, and I also asked the older people in the interviews, how do you think we can get people involved in these conversations, people like yourself? And it was about ensuring that we started early, about ensuring that people were allowed to prepare. It wasn't about preparing you as a professional to go in and knowing what you're talking about. Obviously that's important, but that we should be doing that anyway. It was about enabling this group of people to have time to think about it and talk with their family about it before the conversations. It was about relationships, and it isn't a one-way street. We talk about advanced care planning as autonomous decision making, and that's not really relevant in this group. It's more about relational autonomy. And there were a number of other things, but I won't go on. You can look in the paper if you want to. But it was then about making this into a toolkit that would be helpful for the professionals. So I literally had a laminated toolkit, and then from that, the hospice that I trialled it in as research then decided that actually for them it would be really useful to have it on a little card. So they then decided to design a little credit card size thing, which they now wear on their lanyards, so that it just reminds them. So they have the toolkit if they want to have a little read before they go into practice, but they also have their lanyard, which they've said that they found really helpful when talking to other professionals who aren't engaging older people living with frailty, who've maybe been into hospital 3 times already this year, and it's only, June. Why are they keeping going back? Have we even talked about what they want? So they're finding those cards really helpful as well.
It's really practical
Yeah.
solution. A card is so different from another bit of paperwork.
Yes, exactly. And you can keep it on your lanyard and it doesn't get lost. And then, so that will then, it will develop onwards for the next stage, more focused on the older people themselves.
Yeah, I suppose I did say that was my last question, but I do have to ask one more. Any plans to disseminate with all of the kind of like learning and sort of all of the learning that we as a profession have had to go through in the past around translating hospice practice to hospital, no names mentioned. Are there any plans for it to be something to be adapted for use in hospital? Because that feels like a real opportunity for identifying, finding older people, at the point of admission. That's kind of, in a way, a point that's really ripe for a conversation.
Yeah, there's not at the moment. I mean, I have talked to a number of people in hospitals because, as you say, I've been disseminating it through different organisations, some of whom are much more acute sector led. So there's no plans at the minute, but they do have the respect forms within hospitals. So they are having those conversations. The joining up of the system doesn't always work. Some areas of the UK is great and they do join up, but some areas it really needs a lot of work. So I think I want to get much more of the older person's voice into the booklets and leaflets they might find helpful. And then I think it might be nursing homes might be the first step for me because I'm a bit more community perhaps than I am acute, but I'm open to it.
Yeah, no, nursing homes, care homes, that sounds like it makes a lot of sense in terms of those kind of inappropriate admissions and supporting staff. So, okay, amazing. Is there anything else that you wanted to say about your work or about being a nurse and a researcher or anything at all before I stop the recording, or if we sort of covered it, given a flavour of your work?
I think you've given a flavour of the work, and I think for me it was when I was on my undergrad that I really became passionate about research and the importance of it. So I think if there's anyone that's watching that's interested in taking it further, I think to absolutely do it. It's so important that we engage in research as professionals because we need to ensure we're up to date with everything, but it's also really important that we as nurses are involved in the research. Otherwise, how can you ensure it's relevant to your population? So I guess that's all I would say.
That's really interesting to hear. You're not the first person who has said that when they were undergrad was the first time that they kind of had their interest sparked, and that's very much motivation for this resource. So hopefully that will be happening in real time. So just remains for me to thank you once again, Sarah, for agreeing and giving freely of your time to come and talk to us. It's very much appreciated, and a reminder that the links to Sarah's papers will be at the bottom of this video for you to digest at your leisure. Thank you very much.
Thank you.
Recording now.